Hi, my name is Beidler. This week we are focusing on the role of compliance and information governance. As a healthcare compliance professional, I can tell you that information governance is key to prevention of errors and potential fraud. As AHIMA points out, without a strategy to manage, control, and understand data from EHRs, you really put the organization at risk for many things, including incomplete and incomprehensible health records, the inability to access and use information. So not only is the information either incomplete or illegible and unreadable, but also the information may not be able to be accessed. So there may be some documentation that could be used to support a claim in the documentation, but then the reports aren't able to find it or access it because there's no strategy around information governance. Another high risk that we deal with in compliance is privacy and security breaches under HIPAA or medical identity theft. So when information is either accessed inappropriately or used, not in the correct manner, there can be breaches, and those could have potential harm to patients. Another area at risk is the inability to effectively exchange information. So in Oregon, we have coordinated care organizations where we really have to share information among the partners of this organization. So without having an information governance strategy, it's hard to effectively exchange information. And then another area of risk is copy and paste concerns that can lead to fraud and abuse allegations. I know that our Medicare administrative contractor, Noridian, and all of the other ones across the country are doing audits for copy and paste because this is not allowed for documentation to be submitted for claims. So unless it's done in the right way, but it really shouldn't be used, copying over a chart note, a progress note in the inpatient record over and over without really reviewing and signing off on that documentation and really making sure that it fits the patient's condition for that day. So you might be asking, what does this have to do with compliance? What does compliance have to do with information governance? But really, organizations can be at risk for not having a good strategy around, using, controlling, and managing the data that they have within their electronic health record. And so today we're going to talk about some of the external audits that are going on and the investigations that may occur because of either errors or trends that the government is seeing with the data. So now that we have electronic records, we really do have a lot more potential risk for errors because the government has so much more access to data mining our records. I talked with the Office of Inspector General a while back at a conference, and they were talking about all the different tools and strategies and data mining techniques that they're using to review the data. So really that's why we see a lot of the increases in the audits. So we'll go through, and really this is just to help you as a manager or a director in healthcare information management or wherever you may be, and how to respond to audits or understanding why these audits are occurring and the role of compliance. Either when you're in HIM, you may be working closely with compliance on responding to audits. So we will start that now. Okay. So I love to share this one. This was from the American Hospital Association from a while back, but it's really just a great chart, a great image of what is going on in healthcare. So in the middle there, I always like to think that's compliance, or it really could be any provider that has to deal with any of these entities at one time. So, the large box there on the left is Medicare and Medicaid, CMS, and all of the different ones that work with that entity. But at any time in an organization, you could experience any of these or all of them all at once. I would hope not all of them, but really this just gives you a snapshot of all the different ones, entities that may have oversight over your organization. So we have the IRS, we have the EPA, the OCR, the Office of Civil Rights for either discrimination or HIPAA. and the FBI and FDA for if you have devices and drugs. So just a good snapshot of all the different players in healthcare that may be looking to audit you or investigate. You can also see the state level. We have state surveyors who come out to, hospitals to do quality of care reviews. Maybe they got a complaint or a question from a patient or a family member, and they are going to come out and do a review. So that's going to be an on-site review. They're going to request charts, and they're going to want to look at a certain population and do an investigation. So the different types of audits, the purposes, there may be audits for accreditation, either the Joint Commission or DNV or whatever your accreditation body is. Quality of care, like I said about the state surveyors. The accreditation and quality of care are how CMS surveys hospitals or providers to make sure that they are following the Medicare conditions of participation. So they contract that out either to the Joint Commission or they have the state surveyors doing the reviews. So at any time they could have an implication over your status with Medicare. Medical necessity, those are the big audits that are occurring. Do you have the documentation to support that level of care? With the recovery audit contractors, the RACs, they're really looking at the setting. So because a patient was assigned to be an inpatient, do the records reflect that? So do the records show that the patient was as sick as they are for that billing? Privacy and security, you'll see that a lot of these auditors are looking also at privacy and security of the patient records when they are reviewing and auditing. And also, billing and reimbursement audits. The format of the audits can either be prepayment before the payment is made or retrospective after the fact. So our MACs are doing prepayment reviews, so they will hold the payment until the documentation comes and they review it. Retrospective, the RACs can go back 3 years from the data service, and really if you have a different kind of audit, maybe the ZPICs or one of the others, or an investigation from the Department of Justice, they can go back 10 years. So we need to think about that with our information governance, about retention of data and backups and how records will be accessed going back into the past. So the format can be desk or on-site. So desk meaning an auditor will request records and you'll send them in and they'll review them. And then on-site audits, just as it says, being, coming on-site to do a review. So some of the auditors that we see, we have the Medicaid Integrity Contractors in Oregon, that's HMS. We have our MAC, that is Noridian. Our RAC is Health Data Insights, one of the largest RACs, and our ZPIC is NCI, and we'll go through what these all are. Some of the others, agencies that may do investigations and audits, the Department of Justice typically will do the investigation working with the OIG. So the OIG puts out a work plan annually, and they tell you what they're going to be auditing. So they audit CMS, they're the oversight for Medicaid or Medicare, but they also do audits of providers. So you may see, an audit come through with records going to the OIG. We have the FBI. They typically work with OIG. Either the DOJ or FBI will do the investigation piece. We have the HEAT, the Healthcare Fraud Prevention and Enforcement Action Team. We're really looking at the fraud and abuse. And then other Medicaid audit entities. We now have the Medicaid RACs, and those go along with the Fraud Control Unit and the Integrity Program. And then some states have a State Office of Medicaid Inspector General, like New York, where compliance programs are mandatory for Medicaid providers, and providers have to attest that they are effective. And then the CERT, actually that probably should have been the first slide. So the CERT is where a lot of the RACs came from. That's the comprehensive error rate testing, that they do a random sample of Medicare claims to see what the national error rate is, and that's always changing. So you may have other local and national insurance carriers doing audits, maybe United Healthcare or Regents or whatever it may be. They will also do their own audits, typically following what Medicare is doing. And then your MAC or your carriers may initiate an audit based on reviews of individual claims or whistleblower reports. Maybe a patient has a question about the bill, they don't get an answer, and they are going to complain to the MAC or the insurance carrier, and they'll do an audit. So at any time you could have any one of these auditing your organization. So the MIP and the MIX. These are both Medicaid programs. They're the integrity programs looking at Medicaid integrity. The MIP came first with the DRA, the Deficit Reduction Act. They're both used primarily to oversee what's going on with Medicaid and make sure that they're preventing fraud and abuse. So there are 3 different reviewers or contractors. One will actually analyze the claims looking for potential fraud and abuse. So they're doing that data mining pretty much. And then they will put out audits that they're going to be looking at. So the second one will actually do the audits of the providers looking for overpayments. And then they actually have a third MIC that will do education to providers. So that's one piece that I would say from the provider side that these auditors are lacking is really that follow-up and that education. They pretty much leave it to the organization to do their own education and training. But really with how complex and gray the Medicare rules are and Medicaid rules, it's really good to have that education piece from the contractors at the national level. So what are the MICs looking for? They are looking for typically, what we think of when we think of billing and reimbursement audits. Incomplete documentation, conflicting documentation, improper coding, either overcoding, upcoding, or unbundling of coding. Duplicate billing. That's an easy one for them to find with the data mining. You should have billed 1 unit and you billed 4 or 2. So they're just going to do that 1-to-1 match, and they will easily send you a letter saying you had an overpayment and you should have only been able to bill 1 unit. The hot one now is providing services that aren't medically necessary. And then also they're looking for patient breach, privacy breaches. Okay, so the MAC. The MAC is our Medicare administrative contractor. These used to be FIs and carriers before, and they were consolidated into these regional MACs. So ours is Noridian. When the change came, we really didn't have a change. We'd always had Noridian for Oregon. So they're the payer. They're the ones who are paying our Medicare claims. They are now doing prepayment audits and edits. I mean, they've always been doing edits, but now they're going to be doing audits based on trends they've found, either with short stays, whatever the item may be. They're going to be looking for prepayment before they actually pay. So Medicare is pretty much, they pay on the honor system. Really only 5% of the claims that are submitted to Medicare are reviewed before payment, and that has caused a huge, I'd say, issue. That's why these fraudsters are able to get away with fraud, because you're getting paid and they're not going to be looking back at what's happening. So I think the MACs have been looking at this, and CMS has really tried to do some more prepayment audits. They also have LDCs, local coverage determinations, where each of the regions, each of the MACs does their own review or their own interpretation of the Medicare rules for payment. And that also is an issue we see in compliance, because each MAC has their own interpretation of what the rules are. So that can be kind of difficult when you're having nationwide audits. So when we get to the RAC piece, you'll see that providers can appeal their overpayments based on the Medicare rules, and they can appeal it to the MAC. So the MAC can review those and say, okay, these are actually paid correctly because this was our interpretation and we had our determination out on that. So Noridian does a pretty good job at providing educational services too. I don't know if you've looked at their website, but if you take a look at their website, you can look at Part A, Part B, or DME, and they have a lot of education going on. One of the very high value pieces is the Ask the Contractor calls that they do. So they have open calls where providers can call and actually, ask questions and get some feedback on some of the complicated rules or anything new that might happen. So those are very good. So take a look at those. Okay, so again, Max can audit any claim at any time. They don't audit all the claims, as I said. They will focus their claims that might have potential, high volume of services, high cost, changes in the frequency of use. So maybe you've only been billing, a few of these services a month, and then all of a sudden you have over 100. They're going to look at those changes to see, what's going on. Did you have a new provider? Do they not understand the rules? Whatever it might be, that's what they're looking for. They also have some high-risk problem-prone areas like short stays, 1 to 3 day stays that are considered inpatient by the provider, and maybe that level, that acuity wasn't high enough and that should have been actually an outpatient or observation. And they'll notify the provider in writing when they do the audits. Typically you'll get several notifications, so have your billers watch for that, and then they're going to want to send the records in, and their time frame is actually pretty short. I think they give a 30-day, we have that later, but 30 days to respond with your entire record, which can be tough if you have 10 records being requested at once, and they're all inpatients, and they're all 1 to 200 pages, whatever your printout may be from your EHR. So typically you can send those in by mail, but they also have opened up a portal for providers to send in their documentation electronically. So the CERT, again, that is where all of this came from. They do a random sample of claims received by Medicare each month, and they're looking for just that overall error rate and some of the types and the trends of errors that are occurring. There are several here that do those reviews, so you can take a look at that. You may get a request for a CERT audit. In my experience, we only get maybe a couple, 1 or 2 a year, and they're all over across the board for what they might be. We had one for a lab service and one for an inpatient stay, and that was over a 1-year period. And they also, so if you don't respond to a CERT audit, you can actually have your payment denied and returned, so you'd have to return the payment. And they also can refer you for either to the ZPIC or one of the other auditors for further investigation too. So make sure you're responding to the CERT audits as well. Some of the top, the highest improper payments, this is for Medicare Part B, so outpatient. These are from 2012. Number 1 was chiropractic services. You can see critical care for hospitals, oncology. So if you're doing your own internal auditing, you want to make sure that these are areas that you're looking at because they were on the top the top improper payments for that year. So the RAC, the Recovery Audit Contractors, began, back in, they did a pilot program 2007, 2008, and then it was passed to, because it was so successful, they were returning overpayments to Medicare and, returning money back to the Medicare Trust Fund. It was rolled out nationwide in 2010. They typically use data mining. There are 2 different audits that they do. They do automated audits, so those are, pretty much black and white data mining. You maybe a lot of it has to do with the units billed, so it should have been 1, but you billed 2. They're going to send you a letter saying that all of your services for that type of audit were denied because they found the error. The complex reviews require records, so they require the documentation being sent in. They have, hundreds and hundreds of audit issues that have been approved from CMS to be reviewed. One of the highest, the topics of discussion is how the RACs are paid. So they are paid on a contingency basis, meaning they get commission for what they find. You can see there that 9 to 12% is what they get for all claims, and then for DME, durable medical equipment, they get 14 to 17% for what they find. So really the question is, what is their purpose and their motivation for finding things? Is it because they're getting paid? And that has been one argument that yes, that is why they're finding so many errors, because they're getting paid so much to do it. There are record request limits for providers, which is pretty high. Right now it's 500 records every 45 days for the largest providers, and it really depends on how many claims you've had in the prior year for Medicare. So you can imagine, all of this going on, all of these records being sent out, how busy HIM gets, how busy compliance is, and how busy your clinical documentation group is on doing the appeals. This was from earlier this year for last quarter of last year. The total corrections for the entire program nationwide was $4.2 billion. And that includes both overpayments and underpayments. So the RACs are looking at underpayments as well. So, which I don't understand their math because they add them all together, but that's just showing all of the errors that were corrected. So even if it was underpayment, it was still an error and not correct. So they're totaling those all there. But this is just over 3 years of what has occurred since 2010, and $4.2 billion returned to Medicare. Again, these are just some of the topics, or the summary of what occurred with the RAC action. You can take a look at that. So as of September, there were 664 measures that were approved. So before a RAC can look at an audit type, they need to be approved by CMS. So 664 of those have been approved. Almost 70 added just this year. Some of the new ones for physicians and professional services are, you see a lot with the biologicals and drugs, making sure that the units are correct for what is billed. Outpatient hospital stays billed as inpatient, or inpatient billed as outpatient, both ways there. They're also looking at the therapy caps for physical therapy, occupational therapy, and speech language pathology. There's a cap that has to be reported and on that. They also look at radiology, and these are all just for outpatient and the new ones this year. So you can pull up the Health Data Insights website and you can see they have to post these publicly so you can see what they're looking at. And this all comes down to making sure that you're looking at your own processes and doing your internal monitoring and auditing of the data that's being submitted, because the government sure is. So there's a voluntary report that is done quarterly by the American Hospital Association called RAC Track. This is just for hospitals, but they do a survey. They've showed a continued increase in RAC activity since the survey began in 2010, increased medical record requests, increased total number of denials that are coming through. But then some of the important facts are that 60% of all the records that are sent in to the RACs do not contain an overpayment. This is where we're really scrutinizing what the RACs are doing. I mean, they are returning these overpayments to the government, but what's the cost? What is the cost to providers in responding to all of these? And then of those that did have an overpayment, 44% of the appeals, 44% of the providers are appealing all of these denials because there really have been some questions to how the RACs are doing their reviews. And again, these are the complex reviews where you have to send in your records. And then once they're appealed, 75% of all those appeals are still sitting in the appeals process. So there are 5 levels of appeal, and most of these are sitting at the 3rd level, which is the ALJ, the Administrative Law Judge level, which is where providers have to go to their region, and it's a court. It's a judge who's going to make a judgment on that denial, using your documentation to show why the claim shouldn't be an overpayment or shouldn't have been denied. And again, the bottom line there is that 72% of all those appeals are successful. So we'll see what happens with that large group that's stuck there in the appeals process, but again, we have a lot of questions about the RACs. As I talked about before, the administrative burden of the RACs, and not just the RACs, but all of these audits. 63% of the hospitals reported spending $10,000 or more on managing the RAC process, either through having software that tracks the RAC, the audits, paying someone to do the work. So I know in my experience, I was the RAC coordinator. That was about half of my job, was coordinating all of these audits. So the salaries for that, the resources to have appeals initiated. You may have to have a medical director, physician looking at those medical necessity reviews to make sure that they were appropriate and should be appealed. So it's not just the cost, though, it's the training and education and the process improvement, which I don't know if a lot of providers have actually had time to do. So if you have a denial and you find out that we had a process that was incorrect, or we had a problem with our EHR and our data, it's the fixing of that issue, but then also the training and education that goes with it. So there have been some changes. The request levels, the limits for complex requests and those documentation that has to be sent in, they've been declining, but they are expected to continue. They had some changes with some of the RAC contractors. They were also doing a pilot on prepayment reviews, kind of what the MACs were doing. That's kind of been delayed, but again, they're trying to find other ways to find and return the overpayments to Medicare. So switching gears to the ZPICs, these are the Zone Program Integrity Contractors. They pretty much, their role is to identify potential fraud and confirm that there actually was fraud and do the investigation. So their investigations are initiated either by the data analysis, complaints from patients, or whistleblowers, former employees, or a referral from another agency. So the MAC, the RAC, whoever was looking at that initially may have something that they think looks questionable, and they're going to send it on to the ZPICs. And typically they do come on site for those reviews. What are they looking for? Pretty much what we've been talking about, but the high volume services that are overutilized, medical necessity, looking at just anything that could be a significant problem area. And again, their audits are to confirm fraudulent behavior, not to discover it. So they're doing the investigation piece, and they probably will be working with the DOJ or FBI if there were confirmed fraudulent behaviors. So the Office of Inspector General, the OIG, they've been supervising audits and on fraud and abuse since 1993. They're not just limited to Medicare, but that's who we're talking about when we talk about the OIG in healthcare compliance. So they typically either work alone or in conjunction with another agency like DOJ or FBI or the HEAT. They have the ability to determine fines and penalties, And the thing that you don't ever want is to be excluded from Medicare and Medicaid. They can deem that if they find that you did have some fraudulent behaviors, and you can be excluded from Medicare and Medicaid, which is pretty much the death penalty to us, because you can't really survive if you can't be employed by an organization who bills Medicare and Medicaid. So in 2012, this is their enforcement actions. They had, over 1,100 new criminal healthcare fraud investigations. You can read all the numbers here. 826 individuals were convicted, and even at the end of the year, going into 2013, they had over 1,000 civil investigations pending. So they're busy. Monetary settlements, they won or negotiated $3 billion in settlements and judgments. And again, that death wish, death penalty to us, they excluded over 3,000 individuals and entities from participating in Medicare and Medicaid or any of the federal programs. Going along with the OIG and some of the ZPICs with fraud and abuse is the HEAT task force. They are doing a lot of, they're cracking down on the people and the organizations who abuse the system. These are those, maybe 1% of all the providers who actually do fraud and abuse. That's who they're looking at. They have the stop medicarefraud.gov. They're looking for either patients or consumers to report things that might be questionable, and they're really going to look out for those for the patients. So why do audits? Again, what I said before, only about 5% of the submitted claims are reviewed. It's that honor system. Medicare is trusting us that we have appropriate documentation, appropriate data within our organizations to show that what we are claiming to get paid is accurate. So one of the things here, a small amount of deliberate fraud entities are responsible for the significant amount of the dollars. So it's that small amount of behaviors that have us all working to make sure that we are responding to the audits and make sure that we have to comply with everything that's going on because of these few who are actually doing deliberate fraudulent activities. So the HEAT's looking at those. In May 2013, they coordinated a nationwide takedown, 89 participants in 8 cities, and over $200 million in false billing. So during that takedown, these are the cities where they actually had the activities, and a lot of them, they're in the high utilized, high for Medicare, where all the, they have the highest number of beneficiaries. So Florida, Texas, even Chicago and Brooklyn here, and they're all across the board. I mean, you can see home health, medical necessity, so maybe looking at the physician's claims, and even physical therapy. So they had unlicensed massage therapy billed as physical therapy. 9 physicians, nurses, paramedics, therapists, social workers, rehab facilities, community mental health center. These were all individual indictments, either being excluded from Medicare or Medicaid or receiving a jail time. So far this was from September, the fraud stats were 28 states involved. I don't think that Oregon was one of them because we really don't have a large number of Medicare fraud, but we might have some with Medicaid because we have a higher number of Medicaid recipients. 145 settled cases and 28 publicly reported cases pending as of September. So, the Affordable Care Act, healthcare reform, and has really put some more dollars towards fraud investigations. The healthcare law, we all know it as maybe Obamacare, takes powerful steps towards combating fraud, waste, and abuse. The government has recovered, $10 billion in healthcare fraud in the last 3 years, and they really want to continue with these efforts and make tougher new rules and sentencings for criminals. They've done enhanced screening, so I don't know if some of you might have seen that you've had to renew your provider number through Medicare. They're really making sure that whoever is billing is appropriate and they have been reviewed and renewed. They're also, as I talked about, looking at some state-of-the-art technology with their data mining. They're using predictive modeling technology and really upping their technology in the area of data mining. So anti-fraud efforts are continuing and increasing. So that means for all of us, more audits, more scrutiny on what we're doing. The goal, this was by the end of 2012, which is past, was to reduce overall payment errors by $50 billion and cut the error rate by 50%. I don't know that they were successful in this. Usually we don't get the reports out for a few years, but this is where all the money is going for combating fraud, waste, and abuse. So getting back to some of the improvements that are occurring this is with RACs. This really didn't have a chance of being enacted, 0% chance, but it was brought to the light. This was from the American Hospital Association, really lobbied for this to occur. They wanted, limits on record requests, performance evaluations on the auditors with financial penalties for, low performance, or, we saw that 60% of the records didn't have overpayments, so making sure that these auditors are actually doing what they should be doing. And also requiring a physician review for denials. Right now each RAC is required to have one medical director. Our RAC in Oregon, Health Data Insights has 17 states within it, or maybe even more, so that really isn't very efficient to have one medical director for all of those claims that may be denied. So having more physicians involved with those. So we'll see if this comes back again in 2014. So just switching gears a little bit from the billing and reimbursement is some of the other audits that are occurring. We have the increase in privacy, security, and breach notification audits that are occurring from the OCR. Now that we really are having audits instead of just, the OCR used to do complaint-based audits, so they would only audit you if you had a complaint about, a patient complaining about their privacy rights or a breach with their information, but now they are actually moving this nationwide to do audits for privacy, security, and breach. They had the pilot program that was done last year, and we'll see when we get that final report what they found. And then also, along with data and EHRs, is the meaningful use attestation audits. So for meaningful use 2, we will be seeing more audits occurring on those attestations. So CMS really wants to make sure that what you're saying about your records and your quality and some of the metrics that you're providing can actually be audited and shown to be have meaningful use, being effective. So watch for those. Pretty much if you are sending in your attestation, know that you will be audited. And then with ICD-10, we'll see how that goes. So next October 1st, we will see the ICD-10 implementation. It affects all who are covered by HIPAA, not just those who are billing Medicare and Medicaid. It's hard to tell what's going to happen, but will the government have enough resources to audit what's going on, or will these all be retrospective audits? It really leads us to having to do our own internal auditing to make sure that what we're submitting for ICD-10 is accurate and appropriate. We're going to be going from 14,000 codes to 69,000 codes, and some of those code descriptions are completely different, so it's really going to take us to make sure it's that honor system again, what we're sending in is accurate and complete. So the things that we can do now to be proactive, and not undergo those retrospective audits in the future will really be valuable now. Do you really want to be going back 3 years, if from 2014? So let's say the government finally finds out something was going wrong with those codes. 3 years, you're going to have to go back and check everything. So if they come out in 2017 and they're going to be doing these reviews of ICD-10, do you really want to be going back to correct those? So we really have to be proactive about getting them right the first time. So we're just going to talk a little bit about some of the risky business about errors, and making sure that you actually have some strategies for doing your internal monitoring and auditing of what's in your EHR and what you're billing. Some of the areas for high risk are, the high volume of high level codes without the ability to support them. So making sure that you have your documentation and that you're actually able to access it and send it out if it's being requested. If you're printing on paper, making sure that what you have in your EHR can be recreated in the paper form if that's how the audits are being requested. Any of these here, just looking at, do you have authentication for your scribes, or if you have a scribe following around a physician in the ED, can they sign for things? Can they attest to what they're writing, and then having the physician also sign off on those? Just making sure you have that policy in place. Make sure that you have your time codes for either for psych or therapy documented and having the time in the chart note. For specialty practice, making sure that not every new problem is a new patient encounter, so making sure you have those set up appropriately. Unbundling services, making sure that isn't occurring. Billing for services not accomplished, again, very high risk, we don't want that. Billing never events, so CMS has that list of never events that should not happen, and they will not bill for them. They will not reimburse for them. So, amputation of the same body part multiple times, making sure that that claim is not going out because CMS is not going to reimburse it and shouldn't be billing for that. Another one I talked about earlier with cloning, copy and paste. Making sure that if you are copy and paste from a record, that it is being reviewed, and that you are also citing where it came from. We've seen coding reviews from physicians where they copied the record from the hospitalist the day before. It wasn't their information, it was not cited, and it was the same information, and it was not updated or reviewed. So making sure that it is being reviewed, and that you do have policies in place for cloning and copy and paste. Either maybe your facility does not allow it. For EHRs, it cannot be turned off for most because it is a function of Windows. So I know for Epic, you can't turn off copy and paste because it's tied into the Windows system. Click documentation, making sure that what you're clicking, you don't have things that are pre-clicked, making sure that there is that actual review by the provider when they're doing the documentation. If you're using smart text, making sure that it makes sense for the provider and that it's not pre-filled, that they're actually having to actively review that patient and do the documentation for each individual patient. Making sure you don't have contradictory documentation. They're gonna see it on the other end, and I'll show you some examples here of what Noridian has seen from providers. Garbled documentation, poor documentation. So a lot of times we think that with EHRs we're actually getting rid of some of the illegible documentation, but we can actually create other types of illegible documentation, either with garbled documentation or contradictory, things that are pulled through and just don't make sense about where they're either located in the EHR or where they came from. So the second from the bottom there, printed chart doesn't contain patient identifiers on each page. I remember sending in records to the rack one of the first times, and we were having problems getting our report for the entire record pulled out of the EHR. And once we finally did, we found that our system didn't have the patient identifier on each page, so we had to fix that. We actually had to send, hand write on them the page number and the patient medical record number, and it was just a very difficult process. So making sure that your reports that are going out are complete and appropriate for the audit. So here were the excerpts from Noridian I was talking about. These are actually found in a CERT audit. Would you reimburse this? So this is from the E&M report documentation. His liver alert and oriented ×3 shows a deficit of cognitive function. Our thought physical, psychosomatic eye pupils equal and rectal exam are normal for eczema with inflammation. Yeah, that's kind of garbled. I don't know what they were trying to do, where they, each of these pieces had been. It looks like it should have been on each of the systems, but that is not going to be reimbursed. You can see the other one. She has insomnia. She takes her Tempazam at bedside. She is gestating at least 5 hours a night. Some others, these are time coding statements that just don't make sense. I'll let you read them, but even the bottom one, more than half of a 45-minute visit spent face-to-face with the patient. What happened with the rest of that time? So again, reviewing your documentation to make sure that it is appropriate for the claim. So some of the major audit consequences that can happen, for a lot of these, it's just going to be returning the overpayment. But again, with the RACs, so if you have an inpatient stay, what happens now is, say 3 years ago you had an inpatient stay and they find out it should have been outpatient. Until the RACs change their process, that entire claim is going to be denied and you cannot recoup any of the information, any of the payment. So you can't even get the outpatient stay reimbursed. It's just overpayment, it's gone. You do not have that revenue any longer. Extrapolation, so if the RAC or the OIG finds an error, they're going to extrapolate and show that the presence of this error could be extrapolated across your entire population. So you're going to be looking at some high numbers for overpayments, and then actually it could turn into fines as well. So they can do up to 3 times the damages per occurrence, especially if it's a false claim. So if it's determined to be a false claim, either it was not provided or it was a duplicate payment, you can get up to 3 times the damages for that. Exclusion for Medicare, we talked about that. Also, you can be put in under a CIA, a corporate integrity agreement, meaning that typically for 5 years you will be audited. You will have to spend money to make sure that you have your audits in place, and you're going to be working with the OIG very closely in developing your compliance program. Criminal charges, if there is intent for what was occurring, you can get criminal charges and jail time. Well, and then IRS issues, and then stripes, so the jail time. You can go to jail for billing for fraud and abuse. So some of the frequent audit triggers, chart reviews, any of these here, but the bottom line is that any of these can come from whistleblowers, from either employees, former employees, patients who, they feel frustrated and they feel like they haven't gotten the answers they need. Maybe they called about their bill and they didn't get their questions answered. They're going to talk to someone else about this, and it's going to become, trigger an audit. So making sure that you do have your processes in place for employees to report things either anonymously to your compliance officer, or have a hotline available for that. That's why the compliance office is there. So an elevated risk, misunderstanding of coding guidelines, of course. Misunderstanding of levels of service, that can also be a risk. Having a half knowledge or a lack of knowledge, ignorance is not a defense when it comes to auditing and compliance. Mistakes, mistakes can be a risk, but then if they're caught, they can be easily improved, and you can report what occurred and then move on. But they're not going to be found unless you're doing your internal monitoring, your ongoing auditing at your organization. So don't know, don't want to know, won't change. That is a risk that, we need to make sure that we are following the new guidelines, whatever they may be, the new rules. That's why your compliance program it needs to be effective and ongoing with any of the things that are going on with either Medicare or Medicaid or the audits that are occurring. Education, you're required to know the rules regardless of how many rules there are and how many exceptions there may be to those rules. That one always makes me laugh. I always think of HIPAA with that one, exceptions, and also Stark and kickback too. So if a provider understands and applies the rules correctly, mistakes that result in costly audits are less likely to occur. So reducing that risk, we're just going to finish up here with the importance of the compliance program and the audit plan for your organization. So developing, implementing, and following a credible and effective compliance plan is probably number one reduction of the risk for audits and fraud and abuse at your organization. So having that plan in place, and probably one of the top things to make sure that your organization is doing is having that, a plan of what's going to be audited either by the compliance office or internal audit, or having each department do their own monitoring of what is high risk to them, and then reporting that back to your compliance committee, your audit committee. And then not just doing auditing and monitoring, but the action plan, if there were findings, what are you going to do about it? And then the critical piece is the re-audit, the completing that cycle to make sure that what was implemented is actually working and has changed, what had happened with the errors. So the OIG does put out program guidance on compliance. These are the ones they have to date. It started with the clinical labs in 1997, and then the hospital guide came out in 1998. This is really pretty much the birth of the compliance programs around the country in 1998. There were some follow-up guidance for hospitals in 2005, and the latest one was the nursing facilities. So these are pretty much our roadmap for how we implement our compliance programs. They're not a one-size-fits-all. There's no gold standard. Each program needs to fit the organization's needs, and it's a benchmark of what you need to have, but how does it fit with your resources, your size, and the culture of your organization? You really just need to make sure that you have that culture of compliance, and either that employees feel secure and they're able to report any potential errors that might happen. So with the Affordable Care Act, the Act actually did mandate healthcare compliance programs for anyone who enrolls in Medicare and Medicaid. Means mandatory programs are going to be, coming in the future for anyone, but the rules have not been written yet, so we're waiting to see when that happens. Right now, nursing facilities are mandatory. You do need to have a compliance program, and they're going to be auditing for that, but not for the rest of us yet. So it's still voluntary for us, which can be a good thing because we want to make sure that it fits our organization. But we need to watch out and know that mandatory compliance programs are coming. So what's included in a compliance program? The 7 elements. At a minimum, you should have all of these within your compliance program. Standards of conduct, your code of conduct for your organization, well-written policies and procedures. They are written, they're reviewed. Employees know where they're at, and there is education on the policies. Need to have designation of a chief compliance officer who is a high-level official within the organization and reporting to the board of directors. It really depends on your organization set up and how that chart would, that organizational chart will be. But typically, from my experience and with our healthcare association, healthcare compliance association, this chief compliance officer needs to report to the CEO or the governing board. Compliance education and training. I think we all know that we have the annual compliance training that comes out, but it needs to be robust and making sure that it's working and not just our computer-based training, but ongoing education and training throughout the year. Having that open door policy, the compliance hotline where employees feel safe that they can report something, either stopping by the compliance office to talk with the officer about a concern they have, or just making a report about an error that has occurred. And then a system of response and enforcement. This one's the tough one, disciplinary action, but making sure that you have consistent discipline for anything that's occurring. At your organization, would, if a high-level VP violated HIPAA, and would they have the same consistent disciplinary as a clerk on the floor? So making sure that you have that disciplinary action in place and that you're following that policy. Auditing and monitoring, the one with the elements we just talked about today. Making sure that you have that audit plan in place, that you're following, you're doing auditing, you're having budgeted funds for external audits. You want to make sure that you have everything in place and that you have appropriate coding and billing before any of these audits happen. And then the piece that occurs with the auditing and monitoring is investigations and remediation of any problems. Or, if there's an employee who violated a policy, you need to make sure that you're doing a full investigation and getting back to all the parties involved. So that is all for today. I think we had enough information on auditing and monitoring and how these things are occurring and increasing because of the number of, the amount of data out there, and we just need to make sure that we do have our information governance strategies in place that can help us prevent audits and prevent errors from occurring. Here are some of the acronyms that were used, and then the resources also. And take a look at what's in for this week's materials, and if you have any questions, please email me. Thank you.